Good evening, everyone. Welcome to the MyCP webinar series. I'm your host. My name is Paul Gross, and these webinars are intended to share with the community the work that's going on in the CP Research Network and give you a chance to interact with the researchers and the clinicians that are doing the work. Tonight, I'm very excited to have Dr. Unni Narayanan, who's an orthopedic surgeon from SickKids in Toronto, talk to us about his latest tool. Dr. Narayanan, in addition to being an orthopedic surgeon, is an outcomes researcher and has done some of the most important work in outcomes for children with CP. So the agenda this evening is I'm going to take you through the quick introduction to the CP Research Network. As I always say to people that join these calls regularly, feel free to tune out for about 8 minutes, and then I will introduce Dr. Narayanan, and then we'll do an open Q&A. So the CP Research Network and our merged partner, CP Now, were both born out of an NIH workshop that happened in 2014, where there were 5 objectives that came out of the NIH meeting. And unlike many meetings, at the end, the organizers stood up and assigned to people and to task forces the job of moving these 5 items forward. And I was tasked with another clinician to move forward a national registry, and then very quickly figured out that that really went hand in hand with increasing the amount of comparative effectiveness research, increasing the study of adults, and creating an environment that would bring young clinician scientists into the field. Hadn't originally set out to do basic and translational science, but with the advent of the work by Dr. Michael Kruer, we've been doing work in genetics for the past several years. So we're really formulated to do all of these things. CP Now started at the same time, coming out of the same meeting. Michelle Schusterman, who was the founder of CP Now, was very focused on providing high quality evidence-based information to parents when they got a diagnosis of CP, because of her frustrations 15 years ago finding that kind of information for her daughter. She's also very focused on the well-being of the family that takes care of a child with CP or a family that has a family member with CP. And she was very focused on funding important research. We decided to merge in 2021 under the name the Cerebral Palsy Research Network, or the CP Research Network for short. And our mission is to optimize the lifelong health and wellness of people with cerebral palsy and their families through high quality research, through education and community programming. So some key milestones. We launched the CP Toolkit in 2015. That's been served, not quite as much as McDonald's, but served to more than 4,000 people. We released the Wellbeing Guide for parents and caregivers, and translations of the CP Toolkit into Spanish and Portuguese in 2017. And then we launched MyCP, which is a personalized web service in 2020. In research, we made substantial gains with the launch of our clinical registry that we were set out to define in late 2014 and launched it in 2016, and it now has more than 5,000 patients in it. And we launched a community registry to be able to collect more information about the lived experience from members of the community in March of 2019, and that has over 1,400 people in it. One of the first things we did was we created a patient-centered research agenda. We gathered together people from throughout the community to sort of figure out what was most important to focus our work on. And then we went on to get some public funding for both the registry and for this genetic study that I mentioned earlier in 2019. Since then, we've launched 4 quality improvement initiatives. These are ways to make whole system changes that improve the outcomes for people treated by the system. And we've had 5 publications. We've had over 20 academic presentations, and we still have 6 manuscripts being developed, 2 of which are going to be published, I think, in the next month. And then on the wellness front, we launched a virtual wellness program back in June of 2021, partnered with Staying Driven, and also have since partnered with the National Center for Health, Physical Activity and Disability to promote their mentor or mindfulness, exercise, and nutrition to optimize resilience to the CP community. So we are a 501c3 that brings all these different constituents together to help improve the outcomes for people with CP. We have a physical presence as in the form of a data coordinating center, or a place where all of our registry data comes in at the University of Utah, and it hosts our clinical and community registries, and then our education and well-being programs. I mentioned MyCP. I would encourage everyone that's on the call that's not part of MyCP to join MyCP. It's free personalized web service, and it offers the opportunity for community members to participate in our community registry through surveys, to participate in discussions about research with clinician researchers that are performing the research, and the ability to get personalized web services, as well as access to our free wellness programs. So just to give you an idea of what registries can do, the gross motor function classification system, or GMFCS, is this basic measure of how, or classification of how someone moves. Do they ambulate independently or with assistance, or do they use a wheelchair? And so you can see the distribution, the numbers go from 1 to 5, with 1s through 3 being ambulatory and 4 and 5 not being ambulatory. And you can see the distribution of the people that are in our community registry in terms of their GMFCS. The same data point in our clinical registry. You can see we have, this is from a snapshot before we had 5,000, but you see close to that number. And you see it's a slightly different distribution of people with different GMFCS levels. This is a very important data point for planning and conducting research. This is one of about 400 data points that we collect into the registry. So that sort of summarizes our programs. We're very focused on engaging the community. This picture in the top left are the 45 people that assembled in Chicago in 2017 to set our research agenda. On the right are our clinicians and researchers with a few community members. And then we have our educational programs and our health and well-being programs. The network is spread across the United States. The green pins represent sites that are actively collecting data into the registry. The yellow pins are working on preparing the registry. The red pins are working on compliance and IT, getting IRB approvals and the like. And the blue pins are sites that have raised their hand and said they want to join, but they haven't taken all of the formal steps yet. You can learn the details as to where these pins are on our website at cprn.org. So we are very focused on accelerating research. This is our research pipeline that starts with new ideas being created here on the left that get developed and move through a concept review, get developed into applications, get funded either internally or externally, and then move into study execution. We publish the results, and then we take the results of that evidence and roll it back into clinical practice. So we're constantly learning and developing how we treat people with cerebral palsy based on the evidence and the best practices that have been established. The orange ovals are quality improvement efforts that we've got going. The blue ovals are research projects. And this one right here, CPCHECKlist, is probably actually a little bit further along because it's, well, no, it's somewhere in the stage, but Dr. Narayan will make that quite clear. But that's the focus of tonight's presentation. So I am excited to turn it over to Unni Narayanan, who is, as I said, a pediatric orthopedist at SickKids. He's a professor at the University of Toronto. He's the principal investigator of their priority-based scales for children's outcomes, and he is one of the founding members of the CP Research Network Steering Committee. So without further ado, I turn it over to Dr. Narayanan.
Thank you, Paul. Good evening, everybody. Thank you for joining us. Paul, you're going to let me share my screen?
Yep. Sorry, there you go.
No worries. Is that clear?
Yep.
Excellent. So I have the pleasure of talking about what is the CP checklist, and the the technical definition is a parent-reported index of comorbidities for children with severe CP and CP-like conditions. And I'll explain what that means in a minute. I have, there are lots of people involved in this project from these various institutions as it evolves and into a stage of completion. So over the next 15 or 20 minutes, I'd like to introduce the origins and development of this tool. I'll explain what it's meant to do in the course of that discussion. And I'd like to spend a little time reviewing what the content of the CP checklist to get some idea of what your thoughts might be. Those of you who are watching live or perhaps later when this is archived and accessible to others. And then I want to end by sharing with you what the next steps are to ensure that we're on the right track in the development of this particular tool. So I don't have to tell anybody here about the impact that cerebral palsy has on the person with cerebral palsy who starts off as a child and becomes an adult, to her or his parents or caregivers, to their families, and to the healthcare system. And as Paul alluded to in his brief presentation, there is a range of severity of cerebral palsy on a spectrum that is classified by the gross motor function classification system. At the severe end of the spectrum, you have persons with CP who are reliant on wheelchairs for their mobility and often on a parent or a caregiver for most of their activities of daily living. And these kids and ultimately adults also experience a multitude of health problems. They have seizures. They have visual and hearing impairments. They often have difficulties with communication, with drooling. They have swallowing difficulties that makes it risky for them to be fed by mouth, which makes them malnourished, requiring feeding through tubes in the stomach. They are at risk for developing reflux, which can be quite painful and uncomfortable. They're at risk of developing pneumonias from the saliva or other secretions that they aspirate. They are constipated, they are incontinent, and they have contractures of their limbs and deformities of their trunk and limb, all of which can have a significant impact on their health-related quality of life. And these kids and adults experience or undergo a variety of interventions to address these health problems. They can be procedures for the gastrointestinal system. They could be neurosurgical procedures to deal with their increased muscle tone or their movement disorders. There can be orthopedic procedures to put the hips back in place, to straighten out their spinal deformities, to address their joint contractures. So these interventions are quite intensive. They're resource intensive and associated with lots of complications. And the question is, how successful are these treatments? Do they actually accomplish the goals for which they're intended? And do patients and their parents get what they hope to get or what they want from these interventions? So to answer that question, you have to have a metric that measures that impact of these interventions. And we call these outcomes. So outcomes is the technical term, if you will, for what happens after treatment or over the course of time. We call that natural history. And these outcomes can be desirable, the kinds of goals that we're aspiring to achieve. They could be undesirable. We call those complications or side effects or adverse events. I think we can all agree that a successful outcome would be one where the intervention achieves the goal or the goals for which it was intended. And if that's the case, when we are measuring these outcomes, we need to make sure that the measurement tool that we use reflects and has those goals and expectations of patients and their parents embedded within them. And therefore, they need to be reported by patients and parents, not me as a surgeon to rate how well I think my patient has done after I put their hips back in place. So these need to be patient whenever possible, or when that's not possible, they need to be parent-reported outcome measures. And around approaching almost 20 years ago, this particular quote from one of my patient's mothers really struck a chord. She said, "No one asks me what might make life better for all of us." So when we're thinking about the goals of our interventions, we also have to think about everybody and around the child or the person with cerebral palsy, because they're part of an important unit. So this got us to develop a framework to think about evaluation of outcomes. And in the middle of that framework is the person with cerebral palsy. So in this case, let's consider someone who has severe cerebral palsy, who's in a wheelchair for their mobility and reliant on a parent or a caregiver for all their activities of daily living. What is their lived experience? What is their life like? And only a good understanding of that, which comes from observing these kids in their environment or asking their parents or their family members, can we understand what their priorities might be, what their concerns, desires, needs, and expectations will be, and from which we can ascertain what goals that they might have. But when we think about this, we need to understand that there be many perspectives. There's the parent whose perspective may be the only one that we can access if the child has cognitive impairments that precludes us from ever understanding that child's perspective. There's obviously a child's perspective that we may not know, but sometimes we can ascertain that. There is a family perspective and there's a societal perspective. And you can see that while some of these perspectives might converge, they may also diverge. What's good for the parent may not be so good for the child or for a sibling, and vice versa. So it's important to recognize whose perspective we're talking about and to consider all of these. But a good understanding of these priorities and goals allows us then to come up with interventions to address those priorities and goals. And those interventions, we typically might define in terms of our medical interventions, our surgical interventions and therapy, but we can think bigger than that. It could be in the form of legislation and policies, programs and services, technology, architecture, devices and equipment. But even if we come up with these interventions, we want to know if they actually work. In order to evaluate them, whether they're effective or not, we can do different kinds of research, but then we need to have that metric. We need to have that outcome measure that can tell us definitively whether the intervention or interventions achieve the desired or intended goals. But to develop this metric, once again, you have to embed those goals within them. And if you didn't know what those priorities and goals are, you wouldn't know what it is you should be asking about whether an outcome is successful or not. So this framework that I spent a few minutes on is really key to what has influenced the development of the patient-reported outcome measures for this and other populations. That is the backbone of my research program. And from this work was born the CPCHILD questionnaire. The CPCHILD stands for Caregiver Priorities and a Child Health Index of Life with Disabilities. This came from interviews of parents and healthcare professionals, and it's 37 questions across 6 different domains that generates a score from 0 to 100. And these are the subscales of the domains that this questionnaire touches upon. There are questions about personal care and activities of daily living, positioning, transferring and mobility, comfort, emotions, behavior, communication, social interaction, a whole section on health, and a single item about the parent's perspective on the child's overall quality of life. There's a 7th section that it will be important for this discussion that I'll get back to is, at the end of all of this, we ask parents to also report how important they think each of the individual items are in terms of their contribution to their child's quality of life. So the CPCHILD questionnaire has undergone extensive research by us and by other groups, and enough to say that it works in the way it's intended. It's reliable, it's reproducible, it's responsive. In other words, when there's change, it picks up change. It's reliable, which means it gives you the same score if there's been no change. It has been translated in over 20 languages worldwide, and it's been used as an outcome measure for all kinds of interventions that pertain to those children who I described at first, the GMFCS level 4s and 5s that I talked about. But what's the problem with the CPCHILD and other patient-reported outcome measures? We know that the patient-reported outcome measure is the preferred way to measure outcomes of effectiveness because you're actually getting the perspective of the people to whom this directly matters. So that makes sense. But in order to be a good PROM, it must be relevant and important to patients and parents, which means the content has to be derived from patients and parents. And we did that. However, we have to acknowledge that when a parent or a patient completes a PROM, it imposes a burden on them without any direct benefit to them. You know, they may do this, and for the purpose of research, it tells us how they've done before and after an operation, perhaps, but that doesn't change their individual outcome. So they're spending 20 minutes or more of their time to do this, and we justify that burden because we know that that's the only or the correct way of making judgments about whether our treatments are working, but that's for research. So what's in it for the patient or parent? Is there some way we can actually make this useful to them? So I started to ask this question about 5 or 6 years ago, and we decided, you know, can these patient-reported outcome measures be actually used to guide decision-making? Is there information in the responses that they give us that can actually help us choose what kinds of treatments we need? So I introduced you a couple of minutes ago to the different domains of the CPCHILD questionnaire. And I told you that there was a 7th section about the importance of all the items in that questionnaire. So what we have done is we've modified the questionnaire where against each item, we've asked this additional question: is making a change in this item an important goal for you? So for the 9 items in the personal care and activities of daily living, they respond to that item. And although it doesn't contribute to the score, there will be a separate question saying, do you want to make a change in this item? Is that important to you? Okay. So this is what it might look like. So in the section on personal care and activities of daily living, we asked a question during the past 2 weeks, you know, toileting activities, that is bladder and bowel function hygiene. How easy or difficult is that to accomplish in the usual way? In this case, it's a parent looking after a child, and this parent has said it's very difficult. We then ask how much assistance is required to achieve that task, and in this case, they say total assistance. So the total score for that item is 1 plus 0 is 1. If it was a moderate assistance, they would have scored 1 plus 1, 2, and so on. But here's the third part. How important a goal is it for your child to improve in the following activity? And in this case, the parent said it's a very important goal. So if I had that information, I would have an obligation then to explore this further and say, well, is the treatment I'm going to recommend going to address that goal or not? However, it's quite inconvenient in a questionnaire that has 37 items, then for me to go through every one of those items and to find out, is it a goal or not? So we have developed an electronic version of these questionnaires to report the actual scores. So these are web-based versions of CPCHILD and the GOAL questionnaire, which is another questionnaire for children who are ambulatory with ambulatory cerebral palsy or undergoing gait-related interventions. But for the CPCHILD, you can imagine that this questionnaire will be completed prior to some kind of a clinic visit or a clinical interaction. They would submit it. This would be done on various electronic interfaces of their choice, and it would instantaneously generate a 1-page summary report for the patient parents and also for the clinician. That report would have the total score and the domain scores, which may not mean very much on a scale of 0 to 100, but for every one of the subscales, it would list in turn all the important goals that the respondent identified where things they want to address within those domains or subscales. They could then bring it to their doctor or their therapist and say, what are you going to do about this? And this would be compatible across different platforms and electronic health record systems. So you could imagine that this is what it would look like on August 9, 2019. The parent of this child completed the CPCHILD questionnaire. These were the scores for the total out of 100. They scored 68 out of 100, and these were the domain scores. But again, in red, where the items under that domain that they picked were important items for them. And if you look at this, you know, toileting activities is a challenge, changing diapers and underwear, putting on and taking off low body clothing. They have difficulties sitting in a wheelchair or standing for exercise and transfers. They are uncomfortable, having pain during toileting while seated and disturbed sleep, and this is affecting their ability to attend school and childcare. If I had that information in a very comprehensive and easily accessible way, that might be giving me a clue that perhaps it's their hips that's causing this combination of things, and maybe I order a set of hip x-rays to see if that hip is displacing or dislocating. There's accounting for these combination of problems, or is it something else? But I will be obligated to investigate this and to respond to this. So what we hypothesize, or what we believe, is that this might, and I say might because we need to test this, it might create value for patients and parents. So while they complete the patient-reported outcome measure, it also captures the importance of each of the items to them, and whether making a change in that item is an important goal for them. This capturing these goals will empower parents and patients to articulate their priorities and goals in a very structured and comprehensive way. It might reveal differences in goals between children and their parents, or even between parents. And that would be helpful because they can both answer them whenever that's possible. It can inform clinicians about what problems to focus on in an efficient, comprehensive way. It provides the clinicians the opportunity, and I dare say the responsibility, to respond to the goals that have been identified, even if it means referring it to another kind of clinician whose expertise might address those particular goals. So this could guide decisions and facilitate shared decision-making. It would allow us to manage expectations and help influence that informed consent when we're about to embark on a major intervention, to ensure that the goals that we think that intervention will achieve are aligned with the goals that the parent or the patient is seeking from that intervention. So we think that the combination of this would create value for parents, patients, and clinicians beyond the obvious benefit of tracking outcomes before and after in a way that's meaningful. So benefits the research, but hopefully also benefiting patients and parents, and gives them something back for having taken the trouble to complete these. Now, within the CPCHILD, one of the subscales is one on health. And there was a problem when we applied this particular framework to it. There are 3 items in the health subscale, and they're very generic. So there's one item that asks questions about how much time the last 2 to 4 weeks their child has had spent with a doctor. It's a day, or in the hospital, all the way up to 2 weeks in continuity. So it captures how often they've been in the hospital over the last four weeks. The second question is how many medications they're on. The assumption being the more medications the child is on, perhaps the worse their health might be. And the third is an overall assessment of the child's health based on their parents' perception, from very poor health to perfect health. So even if they say they have a goal to make an improvement of any one of these items, they are very generic goals. Of course, everyone will want to improve their health, but it doesn't give me meaningful information about how to act upon that. So we felt there was a need for a more enhanced health module as a companion to the E version of the CPCHILD, where we would identify specific health issues that could be listed, for which parents could suggest to us whether it's a problem or not, and whether there was a goal to address that. And that is what the CP checklist is. It stands for the Cerebral Palsy, Comorbidities, and Health Evaluation Checklist. And I'm going to tell you a little bit about how it actually developed, the content of it developed. So concurrently with all of this work, we are doing a large international study looking at how effective our interventions are for putting hips back into position for children who have hip displacement. So this is an international study in about 10 countries, in 28 centers. We have over 750 patients enrolled over the last 5 years, and we are following this group until they finish growing and they reach adulthood. And these are the various groups into which they're assigned that are following their outcomes. And the CPCHILD was the outcome measure that we're using. That's the primary outcome measure. So in order to do this study, we know that all those health conditions that I initially talked about, their seizures, the method of feeding, whether they've got reflux or not, whether they've got visual impairments or hearing impairments, in previous work, we have shown that the more severe the seizures, the worse the CPCHILD scores. If they're fed by a G-tube, they score worse on the CPCHILD than if they're fed by mouth. So if that is true, it is really important in any study like this that we are also capturing how, whether they've got these other comorbidities or health conditions, how severe they are. And we did that for the CPCHILD, for this CHOP, what's called the CP-HIP Outcomes Project, or the CHOP study. So we've got those data for 750 patients on what, about their seizures, their visual and hearing impairments, how they're fed, whether they've had pneumonias in the past year or not that required hospitalization, and so on. So we were able then to check to see whether, as they had these health conditions that affect the CP-CHILD scores, and indeed they did. And we found that those relationships were so strong that we could use the wording in which we had found out about these comorbidities or health conditions, as we did for this particular study, and embed that into this checklist that we talked about. I'm not sure if you can read this, but we'll give you a bigger version of this. So for example, the seizures, the parent, all they have to say is that their child has seizures or not. If they have seizures, do they think the seizures are controlled or poorly controlled? And then they say, is this a priority goal for you to address at this time? So this is what we developed for 25 different health conditions. So these items were derived from that CHOP study, and we created this report form, if you will, for these comorbidities, which is another word for saying various health conditions. And then about a year ago, with my colleagues in CPRN, we looked at this preliminary version and got them to tell us what they thought about how useful this would be, about the wording, the structure, the format. We followed that up with a large international survey of healthcare professionals who are familiar with this population to get their input. And we came up with the next version of the CPCHECKlist, which has two parts, with these 22 comorbidities and 9 health technologies. And I'll get to that in a minute. So we evaluated how sensible this was in that survey, and we got a good response rate, and about 80% said accept it as is, and about the other 20% gave us very useful feedback on certain modifications we should make. They suggested adding 3 items, and we took their feedback and came up with the final version that I'd like to go through over the next couple of minutes. So again, seizures, never had seizures, no seizures in the last year, seizures controlled, seizures poorly controlled, and then adding unsure, they don't know, maybe it's a seizure, maybe it's not, they don't really know. And then they say, is this a concern or not? Is it a somewhat of a concern or an important concern? And again, I'm not going to go through each of these in detail, but there's sleep difficulties, mood and behavioral problems, vision, hearing, drooling, dental and oral hygiene, swallowing difficulties, breathing difficulties, pneumonias, reflux, feeding difficulties, including the method of feeding, nutritional problems, bladder and bowel issues, involuntary movements of the limbs, the neck or the trunk, contractures of the upper limbs, a curve or twist of the back or spine, contractures of stiff joints in the lower limbs or the legs, and pain, and if so, where it is, skin problems, etc. And the option to add others if we've missed anything. And the second part is for each device or health technology that their child might use, do you think there's a problem or concern that needs to be addressed at this time? And there are all these different health technologies that some of these kids have. Not all of them have everything, but many have many of these. They could say, does not use it, it's not a problem or concern. Yes, there's a problem or concern. And that then allows us in a very comprehensive way for us to make the appropriate referrals to address some of these technology concerns. And if they don't use this, it's an opportunity for them to be asked, would you like to discuss or learn more about some of these if they've never been discussed with you, to see if your child is a candidate for this? Well, that's all very well. Now we've got to validate it, which is the next step. So we've done the sensibility evaluation by clinicians and researchers from multiple disciplines. But remember, this is meant to be for parents. So we need to do the next step, which is to establish the sensibility of the CP checklist by parents and caregivers of children with severe cerebral palsy and CP-like conditions. And sensibility is really the technical word for saying, does this make sense? Is this feasible? Will this be useful? Does it capture the things that are important to you? What's missing? What's redundant? Give us your feedback. we want to know if this is meant to be a simple and comprehensive way to communicate one's child's related concerns to a clinician, and the results we think will inform the final content and structure of the CP checklist before we do the third step, which is to actually validate it in real practice, where we will test it out in different healthcare settings to see indeed if it is as useful as we think it might be. So there are many ways of establishing the validation of the CP checklist. These are technical, research-related methods that I'm not going to delve into. Suffice to say, we need to do those tests in order to be sure that it is measuring things in the way we want it to measure. So here's a timeline. We've done that first part, and we are right in the middle here. We're about to embark on the second aim, which is to elicit solicit parents and caregivers to give us important feedback about the utility of the CP checklist before we develop the final version for that validation. And this project has received some partial funding through my collaborators who are listed here, including Paul Gross and Michelle Schusterman, who are not only represent the community, but also two important organizations that have emerged. And my other collaborators, including Laurie Glader, who's a big part of this, who's a development pediatrician and a complex care pediatrician, Darcy Failings, a development pediatrician and an amazing colleague of mine here in Toronto, Gary Norritz, who's at Nationwide Children's Hospital, Kirk Graham, Mark Camp, George Ibrahim, Brandon Rocks. We can see orthopedics, neurosurgery, physiotherapist, even anesthetist. So these are the various stakeholders who are contributing to this work. So I'm going to stop right there, and hopefully there should be time for questions.
Unni, I'm sure there's time. So I think what we can do is people can unmute and ask their questions, or if they prefer, they can put a question into the chat. But we're a small group, so hopefully people will unmute and dive in. As always, Unni, I have questions. I know I've asked this, but for some reason it doesn't stick in my head. So as you were presenting, you talked about the need to test this, and you were talked about it in conjunction with sort of I think with Goal and CPCHILD. So I just try to understand how could it possibly not help to have one of these things facilitate decision making? I mean, what will be the measure of success as to whether or not it's helping? What can you describe a little bit about? Because to me, it just as a layperson, I just kind of go, of course this is going to help. So I'd love to hear what it is that you kind of feel like you're getting into by measuring that.
Sure. So first and foremost, the first test, if you will, is I might think it's a great tool, but I want to make sure that the people for whom it's intended think it's a great tool or a useful tool for them. And that's a simple issue of asking them in a way that allows them to give us, measurable feedback. So, which is, so we'd send them a survey, they'd look at it, complete it, and say, all right, on a scale of 0 to 5, this is too difficult, or I don't understand this. It's about, is it comprehensible? Is it comprehensive? Is it redundant? Is it feasible? Do they think it will be as useful to them for that purpose? So that's one facet of this. And what might seem self-evident to me, and I'm glad to hear you, may not be the case. They may tell us that some of the words you've used, I don't understand those words, and we don't think of it in those ways, etc. So we need to really do our due diligence there. So that's one aspect of it. At that point, it doesn't matter what we as clinicians think. If the parents and consumers feel that that's really helpful, then I think the clinician is more likely to pay attention and say, okay, give me that information. I'm supposed to be getting the information from you anyway, but I might forget to ask all these things. If you complete that ahead of time, maybe once a year, etc., then multiple disciplines can look at that information, because as an orthopedic surgeon, I can only address a handful of those things. But if it's But if you've done it, I can then make the appropriate referrals to other people, etc. So testing that would be to see when we actually apply this, does it actually facilitate shared decision-making? Do we find that my colleagues are responding to the effort that our patients and parents are taking? And do parents also notice that? Yes, when I did this, I felt that they responded. So that's the aftermarket surveillance, post-market surveillance, if you will. So those are the elements that I'm talking about testing. There is one other part that is more technical about using this as a measurement tool, because someone who scores to the right of that scale, where it's more severe, less control, and is seeking some help with it, those kids by definition are less healthy than kids who don't have those conditions. And a sum of those scores might provide an overall index score of their health, from excellent health to very poor health, which might be very useful for researchers when they are trying to balance, if they're doing a trial comparing one group that had treatment A and one group that had treatment B. Treatment A did better than treatment B, but they may find out that, the kids in treatment B were much of poorer health. So if they had a way to measure that health, then they would, in a standardized way, they could control for that. So for research purposes, this becomes incredibly important as well. And that's where we need to test. If parents complete it twice, will you get the same responses? If one day they say it's severe, and when something hasn't changed, the next day it says it's not severe, then which one do we believe? So it has to be reliable. So just like any weighing scale, you stand on it, it tells you you're 70 kilograms, you get off it, and you stand on it again. Now it tells you you're 85 kilograms. Well, that's not reliable. Which one do you believe? So there are these technical tests of any tool that we need to test.
So I get that. Let me just ask one more question about the sort of shared decision making. It seems to me that so much of whether or not it's effective as a shared decision making tool has to do with the attitude of the clinician and the attitude and comfort of the parent. To the degree that the parent feels comfortable, feels that the physician is open to sort of, suggestions, questions about this, and how the physician carries themselves. And does that get measured in some way? Because I got to believe that's a big factor in its effectiveness.
Absolutely. So one of the things that we're going to measure at the time of that third step of validation, at the same time as we get them to complete this, they will have done it in the context of some clinical interaction with a physician or a therapist. And we're going to give them another questionnaire, just called the Shared Decision-Making Questionnaire 9. It's a 9-item questionnaire that allows them to evaluate how much they thought they were listened to and responded to, etc. And we'll do the same thing with the clinicians as well. So that's part of this that project. But to answer your question, we think that this may facilitate shared decision-making. By completing it and generating a report of all the things that are problematic to them, parents don't have to remember them. They've got busy lives, etc. And any clinician that is giving this or making this accessible to a patient presumably wants to get that information. And if the parent can then, I think it potentially empowers them then to say, look, these are the goals. Can you help me with this? Maybe you can't help me, but tell me who I should see. Or so I think it is a facilitator for them to move the needle forward. And it helps me as a busy clinician to I may focus on a very narrow orthopedic issue where right now on their mind is something totally different or something else. And we can still get to the orthopedic issue, but I have a responsibility then to make the appropriate referrals. So that's how I hope it could work.
Yeah, I'll come back to that. Poonam and then Christine. So go ahead, Poonam. Maybe Poonam was just waving, but probably searching for the mute.
Yeah, no, I was trying to get the video on, sorry. Yeah. So very nice presentation, Dr. Unni. I really enjoyed learning how this checklist was developed. And I had a few questions, some quick ones and some maybe more involved. So one is this checklist then spans like the whole, like right from the beginning, right? Like Jay was diagnosed at 9 months of age. So would this be administered right from the start, or
Yes. I think that the way we chose the items, they're applicable to the entire age span, and could be useful in adults as well, because those conditions don't go away. So right now, it may, but the answers that a parent gives when the child is 9 months old or a year old, maybe without a seizure disorder that's evolved yet, might change when they're 12 years old, of course. But the content seems to be applicable to the full spectrum of ages.
And as far as the interventions go that are listed on there, and I didn't kind of capture everything that's listed on there, but in our experience, depending on the providers who we went to, we would be offered different interventions. So I'm wondering when this, I'm assuming that this is going to be broad-based, that eventually you would expect everyone to implement this as a universal checklist. So some providers don't believe in some interventions, so they may not advocate for them, or they may say it's there, but how will that be dealt with at different sites and providers?
Right. So there are really no interventions in the checklist. It's only about the health. Perhaps you're talking about the health technologies like standards or a VP shunt, for example. Those are certain health-related technologies like wheelchairs or orthotics or braces and so on. These are things that we provide to these kids. Not everybody uses them. Mm-hmm. If there's a problem, they will identify it and tell us, please help us with it. If it's not a problem, then that's fine. Or if they want more information about it, a clinician can say, I don't believe in that. It doesn't work. And that's fine. That there's no imposition here on what the clinician should do. And there's no interventions within that checklist that are actual treatments, unless you count the method of feeding as a treatment. They have G tubes, GJ tubes, or parental methods of feeding. But otherwise, there's nothing about what kinds of operations to do or anything like that.
Like, for example, Botox for spasticity.
There's nothing about Botox.
There's nothing there.
No, nothing about it.
I think it's important to point out, Poonam, that I think that the issue that you're talking about will be addressed. Dr. Narayan's been participating in a process that's nicknamed Mission Impossible, where all of the orthopedic surgeons are writing down their indications. What are the sort of signs and symptoms they look for to do a particular operation, and seeing how much agreement there is. And then over time, what we can do is start to look at, do they do what they agree on, and generate evidence for what produces the best outcome. And I think that's the whole concept of the Learning Health Network that we're building, is the way in which we might get to the point that for a given patient interested or patient family being interested in improving this thing, that there can start to be evidence that says these interventions have these impact on this outcome.
But just on the question you raised about Botox, for example, if a parent reports that my child in the lower extremities has very tight muscles that are interfering with care, and this is a problem I'd like attention, something done, this is quite severe, and it's a goal for me, then the clinician can decide from their armamentarium whether they want to give Botox or baclofen or therapy. There's nothing prescriptive about what treatments to give. It's just that whoever the clinician is and whatever whatever is in their expertise or what they believe in, they can then say that this is what I have to offer you for that particular problem. So that's the intention.
Okay, got it. Thank you.
So Christine, you're up, or if you would prefer, I'm glad to read your question for you.
Sure, go ahead and read it. Thanks.
Okay. Could this CP checklist also be utilized for children with other diagnoses, such as those with genetic disorders who also look similar to those with CP due to seizures, cognitive impairment, visual impairment, G-tubes, and communication disorders?
The short answer, Christine, is yes. This is intended for the phenotype, if you will, of a child who has this combination of different things. They're in wheelchairs for their mobility and rely on a parent or caregiver for some or more of their activities of daily living. And so this is intended for CP and I've in quotes CP-like conditions, even if they're progressive, whether they're genetic or otherwise. So we think, yes, this will be. And one of the groups that will be testing this will be the complex care group, because children medical complexity will capture that population you're talking about for sure. Metabolic disorders, for example, traumatic brain injury, for example. So all of those things would this might serve that purpose. Yes.
Great.
Amber, you're. Oh, sorry. Yes, Amber, you're up.
Yeah, I was wondering on the form, is there moderate assistance on there also? I mean, because it's very similar to the FIMS, or some of it is similar to the FIMS score. So I didn't see that on there. So I was just pointing that out just to ask and see if that would be put on there if it isn't on there.
So it's a good question. This is not an outcome measure. This is not a way. So the CPCHILD has exactly that, what you're talking about. The main body of CPCHILD, talks about how much assistance is required to achieve a particular task. Everything from total assistance, a moderate amount of assistance, supervision, or it's done independently. So a task might be easy to do or very difficult to do. However, it's done typically and may require total assistance to no assistance whatsoever. So whereas in this, it's about the health. It's about a health-related issue. And we're just talking about, is it there? And if it is, can we quantify how severe that health issue is? If you've got seizures, is it controlled or poorly controlled? If you've got respiratory problems, is it mild, is it moderate or severe? A severe might require, and there's some definitions there, where they need a breathing assistance with a tracheostomy, or you need a ventilator. So that's the intent. I hope that answers your question.
Yeah, it does. I also just wanted clarification on the part where you said salvage. I don't know what the other word was, but it was salvage something. What is that? Is that like if surgery goes wrong or an intervention goes wrong?
I should have taken all of that up. That was for the CP Hip Outcomes Project, which listed 5 different types of ways we treat hips. 1 is doing nothing, that's natural history. 2 is with serial Botox injections. 3 is with just muscle lengthening procedures. 4 is with reconstructive procedures that involve the bones and the muscles. And salvage are children who've had long-standing dislocation. The hip has been out for a long time. The head has lost its shape completely. It's very painful. It's arthritic, and that there is no way to put that hip back in place. It's destroyed. So then we have to do these salvage procedures. Salvage means to salvage that situation. We remove the femoral head altogether and create an artificial head, if you will. There are many different kinds of salvage procedures. So we just want to categorize those.
Okay, and then
that's separate from the CP checklist.
Yeah, thank you for clarifying that, because I wasn't sure what it meant. I also want to know, is there going to be a way to bridge this to adults?
Yeah, I mean, I'd love to hear what you think. If you said to me there are things here that would equally apply to adults, then yes, I don't see why we wouldn't use it. We may change some of the wording, saying rather than your child, but the person you're caring for. We can change that language or adapt it as is necessary. But for now, we're validating it in that population up to young adults. But as I learn more from people like yourselves, hopefully, this might have a broader application across the age span.
Thank you. I think it's a beautiful tool. I think it's going to give some very good information. So thank you very much. Do you have an email? Amber. Are you going to have an email that we can reach you at if we have ideas?
Send me a mail, Amber, and I'm glad to get it to Unni, yes. and I can connect you. I just want to give the last question that's in the queue. I wanted to give Jay an opportunity to ask his question, and then we can wrap up.
Yeah, hi. I was just kind of curious with this particular measure, like how closely the questions are tied to like functional activities. So like, I think I gave the example of like, is the individual able to walk around their school building, or like, are they like able to like participate in like a meeting and speak in a meeting without like having breath support issues? Because I feel like those kinds of things are easier to identify whether they're important if you just talk in general about like breath support, for example, and not tie it to anything specific. So I was just kind of curious, like what the thinking was related to that.
Thank you, Jay. This is intended for that severe end of the spectrum of cerebral palsy. So these would be children who are not able to do any kind of functional walking. They may use a walker for exercise purposes for short distances, but for the most part, it's the wheelchair they're reliant on. So on the specific question of their ambulation, it wouldn't apply. But the second part of your question was other aspects of their function, and that will be captured in the CPCHILD. So in the CPCHILD questionnaire, which is the actual outcome measure, the issues around some of these things that you talked about would be captured. You'd have to look at the items to see which ones that I mean. So this CP checklist is meant to be either a standalone tool to capture who's got these health issues and what we should do about them, and as a companion to the CPCHILD, which is being used to get the goals from parents, what they want. These are the health-related goals, and the other goals of the CPCHILD will come from the CPCHILD goals themselves. So I hope that clarifies your question.
Yeah, I think so. I think maybe later on I'll see if I can take a closer look at some of the questions that are actually asked.
I think that, and I will send to Paul, the CP checklist and the CPCHILD, so that you can, that people can take a look at them.
All right, so we had a final comment from John Borland, who says, sounds like a great tool. Wish something like this would have been available in the 50s and 60s when I was undergoing corrective surgeries and procedures. So Unni, you just, well, anyway, just no jokes about that. But anyway, thanks for your comments, John. Unni, Dr. Narayan, thank you so much for your time. I know we had a small, intimate crew, but I promise you this will be viewed by many. So I appreciate your time and thoughtfulness in explaining this in such a lay-friendly manner. So thank you. And thanks everybody for joining us this evening.
Most welcome. It was a pleasure. Thank you, Paul, for the opportunity.
Okay. Goodbye.
Thank you.
Bye, everyone.